Hey guys, welcome to another episode of the Human AI podcast. Today we're gonna do a lighter topic. We're gonna do some history taking. Very important. It's lighter because it's a bit more, we don't need to locate the posterior ascending arteries and everything. So, let's talk specifically about cardiovascular, respiratory, and GI. So I'm here with Grog, who's gonna help us out. So, Grog, let's say a patient comes in and it seems that something to do with the cardiovascular system that's their presenting complaint. What do I do?
When a patient presents with cardiovascular complaints, examples, chest pain, shortness of breath, start with a focused history. 1. Ask about the chief complaint, onset, duration, location, quality, examples, crushing, sharp, severity, 1 to 10, radiation, examples, to arm, jaw, and associated symptoms, nausea, sweating. 2. Check past medical history, heart disease, hypertension, diabetes, medications, allergies, family history of cardiac issues, and risk factors, sicking, obesity, sedentary lifestyle. 3. Clarify exacerbating relieving factors, examples, rest, exertion, and recent events, trauma, stress. This guides your differential, examples, angina, MI, aortic dissection. Want to roleplay a sample history or move to respiratory, GI?
So I will use the Socrates acronym.
Perfect. Socrates is a great tool for cardiovascular history taking. For a patient with cardiovascular complaints, apply it like this. Site. Where's the pain, chest, arm? Onset. When did it start, sudden, gradual? Character. Crushing, stabbing. Radiation. To jaw, shoulder. Associated symptoms, sweating, nausea. Timing. Constant, intermittent. Exacerbating relieving factors, worse with activity, better with rest. Severity. 1 to 10 scale. Add past medical history, risk factors, smoking, hypertension, and family history to flesh it out.
Okay. And tell us about following the Socrates acronym, tell us about, well, let's say we have chest pain. Tell us what would we be expecting regarding site, onset, character, etc. Please.
For chest pain using Socrates, site, typically central chest, substernal, or left-sided, may feel diffuse.
Sorry guys, I had a positive housemaid intervention for 30 seconds just to say hi. Okay, let's restart back into it. So tell us again about chest pain. You mentioned site. Let's complete it. Let's say severity, exacerbation, timing, all the Socrates.
All right, let's dive back in with Socrates for chest pain. Site, central chest, substernal, or left-sided, sometimes diffuse. Onset, sudden, examples, heart attack, dissection, or gradual, examples, angina. Character, crushing, heavy, ischemic, sharp, pericarditis, tearing, dissection. Radiation, to left arm, jaw, neck, ischemic, back, dissection, or none. Associated symptoms, sweating, nausea, shortness of breath, palpitations. Timing, constant, infarction, hours, intermittent, angina, minutes. Exacerbating relieving factors, exertion worsens, rest nitroglycerin, relieves, angina. Leaning forward helps, pericarditis.
Okay,
Severity.
so what about breathlessness? What should we be expecting regarding orthopnea, swelling of the ankles, paroxysmal nocturnal dyspnea?
For breathlessness, dyspnea, and a cardiovascular history, use Socrates and probe specific symptoms like orthopnea, ankle swelling, and paroxysmal nocturnal dyspnea, PND. Sight, chest or lungs, generalized breathing difficulty. Onset, sudden pulmonary edema, embolism, or gradual heart failure. Character, tightness or inability to breathe deeply. Radiation, typically none. Associated symptoms, orthopnea, breathlessness lying flat, suggests heart failure, forcing upright sleeping. Ankle swelling, edema, from right heart failure or fluid overload. PND, sudden waking at night gasping, due to fluid buildup in lungs. Timing, intermittent, examples, exertion triggered or constant, severe heart failure. Exacerbating relieving factors, worse lying down, orthopnea, better sitting up, exertion worsens. Severity, mild, exertion only, to severe, at rest, 8 to 10 out of 10. Ask
Okay,
about sleep.
let me ask you about palpitation. What should we be expecting in regarding to heart fluttering, some kind of irregular rhythm? Um, yeah. Is it important to know the frequency, the duration?
For palpitations in a cardiovascular history, Socrates helps, focusing on heart fluttering, irregular rhythm, frequency, and duration. Sight, chest, felt as heart racing or skipping. Onset, sudden arrhythmia like AFib, or gradual anxiety related. Character, fluttering, pounding, irregular, or regular thumping. Radiation, usually none. Associated symptoms, dizziness, fainting, syncope, suggests serious arrhythmia, shortness of breath, chest pain. Timing, episodic, seconds to hours, or persistent. Frequency, daily, weekly, and duration, seconds, minutes, are critical to distinguish benign. Examples, preventer contractures from dangerous. Examples, ventricular tachycardia. Exacerbating relieving factors, triggered by caffeine, stress, exercise, may stop with rest or Valsalva maneuver. Severity, mild, annoying to severe, with syncope, 7 to 10 out of 10. Ask about triggers, lifestyle, and family history of arrhythmias. Want to practice a palpitation case or move to respiratory?
I want to ask about claudication pain.
For claudication pain and a cardiovascular history, typically linked to peripheral artery disease, PAD, use Socrates to guide. Sight, calf, thigh, or buttock, unilateral or bilateral. Onset, gradual, triggered by walking or exercise. Character, cramping, aching, or tightness, not sharp. Radiation, usually none, stays in muscle group. Associated symptoms, leg fatigue, numbness, weak pulses, rest relieves pain, unlike neurological pain.
But
Timing.
why would we have this calf pain? I don't understand the reason.
Claudication pain in the calf occurs because peripheral artery disease, PAD, Narrows leg arteries, reducing blood flow and oxygen to muscles during activity like walking, causing cramping or aching. Rest relieves it, as muscles need less oxygen, unlike neurological pain, which persists. Want more on PAD causes or how it ties to cardiovascular history?
I just don't understand why the calf means vascular disease if you have pain.
Calf pain and claudication signals peripheral artery disease, PAD, because narrowed leg arteries, often from atherosclerosis, limit blood flow, starving calf muscles of oxygen during activity, causing cramping pain. Pain stops at rest when oxygen demand drops, a hallmark of vascular, not neurological issues. Want details on atherosclerosis or diagnostic tests for PAD?
I want to ask about some past medical history, like that I should be asking if I'm seeing that it's a cardiovascular problem. But explain us again why calf means vascular disease.
Why calf pain means vascular disease. Claudication pain in the calf points to peripheral artery disease, PAD, because atherosclerosis narrows leg arteries, reducing blood flow. So during activity, examples, walking, calf muscles lack oxygen, causing cramping or aching that stops with rest, unlike neurological pain, which isn't exercise dependent. Past medical history to ask for cardiovascular issues. Heart conditions. Prior heart attack, angina, heart failure. Hypertension, diabetes, high cholesterol, atherosclerosis risks. Smoking history. Packs per year, major PAD heart disease risk. Family history of heart disease or PAD, genetic predisposition. Previous vascular surgeries or stents. Medications, statins, antihypertensives, antiplatelets. Rheumatic fever or endocarditis, valve damage risk. Recent trauma or immobility, clot risk. These clarify risk factors and guide diagnosis. Examples, PAD.
Dude, is it because of gravity or something?
Calf pain and claudication isn't directly due to gravity, but because peripheral artery disease, PAD, narrows arteries, often in the legs, limiting blood flow to calf muscles during activity, causing oxygen shortage and cramping. Gravity can worsen symptoms in advanced PAD if blood struggles to reach lower limbs, but the primary issue is atherosclerotic blockages. Want to dive into PAD's vascular mechanics or stick with history questions?
Well, let me ask you. So, okay, maybe we want to ask, did they have hypertension or diabetes? What drugs do they take? What family and social history shall I be asking?
For a cardiovascular history, especially with suspected issues like claudication or PAD, ask: hypertension. Do you have high blood pressure? When diagnosed, controlled, increases atherosclerosis risk, contributing to PAD heart disease. Diabetes. Do you have diabetes? Type 1 or 2? How long? Controlled. Damages blood vessels, accelerates PAD. Medications. What drugs do you take? Statins for cholesterol, antihypertensives, antiplatelets, aspirin, clopidogrel, diabetes meds, or heart drugs, beta blockers. Any recent changes? Family history. Any family with heart attacks, strokes, PAD, or sudden death before age 60? Genetic predisposition to vascular disease. Social history. Smoking, how much, how long? Quit when? Major PAD risk. Alcohol use. Diet. High fat, sugar. Exercise level. Sedentary worsens PAD. job, or stress factors. These pinpoint risk factors, guide diagnosis, and inform treatment. Examples: lifestyle changes, statins. Want to roleplay these questions or move to respiratory history?
Well, I'm happy with cardiovascular. Let's move to respiratory, and then when we finish CVD, respiratory, and finish GI, we'll do some role play. Yeah, let's kick things off with respiratory history. So, what are some common symptoms to inquire about?
For a respiratory history, focus on these common symptoms: shortness of breath, dyspnea. Onset: sudden, gradual. Severity: at rest, exertion, duration. Triggers: dust, exercise. Cough: acute, less than 3 weeks, or chronic, productive, sputum color, amount, or dry. Timing: night, morning. Wheezing: high-pitched sound associated with asthma, COPD. Triggers: allergens, cold air. Chest pain: pleuritic, sharp, worse with breathing. Examples: pneumonia, or non-specific. Sputum hemoptysis: blood in sputum. Quantity, frequency. Examples: cancer, TB. Associated symptoms: fever, weight loss, night sweats, infection, malignancy, fatigue. Ask about exacerbating relieving factors. Examples: inhalers, position, and use Socrates for symptom details. Want to dive into one symptom or cover past medical history next?
Sorry, guys. Okay, what about sputum, cough, hemoptysis, wheeze? Like, I get confused a bit when. So, these symptoms, I associate them with a general respiratory disease, but I never, know which one is more for which disease. And what's the difference between illness and disease?
Let's unpack sputum, cough, hemoptysis, and wheeze, their links to respiratory diseases, and clarify illness versus disease. Sputum: mucus coughed up from lungs. Yellow-green, purulent. Bacterial infections, pneumonia, bronchiectasis. Clear, frothy. Pulmonary edema, heart failure. Chronic, copious. COPD, cystic fibrosis. Cough: reflex to clear airways. Acute, productive, with sputum. Pneumonia, bronchitis.
I can't wait to go to the hospital because I bet when I see cystic fibrosis in the hospital, I will never forget it. It's gonna be like a terrifying experience. I will remember it. But in fucking theory, it's like talking about a different thing. Anyway, sorry to interrupt you. Okay, what are some good questions? Let's say someone comes and they're breathless. What shall I be asking them?
No worries. Hospital experiences do burn stuff into your memory. For a patient presenting with breathlessness, dyspnea, ask these targeted questions to build a respiratory history. Onset: when did it start? Sudden. Examples: pneumothorax, embolism, or gradual. Examples: COPD, heart failure. Severity: how bad is it, 1 to 10? Breathless at rest or only with activity. Examples: climbing stairs. Duration: how long does it last? Constant.
Okay,
Or-
I get kind of the point. So, just a sec, guys. So, okay. What are some good questions regarding coughing and sputum? If you could talk a bit faster too, and hemoptysis too, and wheezing.
For coughing, sputum, hemoptysis, and wheezing in a respiratory history, ask cough, how long? Acute, less than 3 weeks, example, infection. Or chronic, more than 8 weeks, example, COPD. Dry or productive, worse at night, asthma. Or morning, bronchitis. Triggers, smoke, cold, sputum, color, clear, yellow, green.
A bit
amount.
slower. Cut the difference in terms of speed. Jesus fucking Christ, dude.
My bad. Let's dial it back. For coughing, sputum, hemoptysis, wheezing, cough, how long's it been? Dry or productive? Worse when? Night, morning. Any triggers? Smoke, dust, sputum, what color? Clear, yellow, bloody. How much? Teaspoon, cup, thick or thin? Hemoptysis, blood and cough. How much? Streaks, clots. How often? Recent infections or weight loss. Wheezing, high-pitched sound when breathing, constant or episodic. Triggers, allergens, exercise, relief by inhalers. What's next?
Fucking hell, dude. A bit slower. Let's talk more only about, let's just do 2 sentences each, and let's start with wheezing only now.
Wheezing is a high-pitched whistling sound during breathing, often linked to asthma or COPD. Ask about triggers, allergens, exercise, and relief inhalers. What's up next?
One more time.
Wheezing, a whistling breath sound, suggests narrowed airways, common in asthma or COPD. Ask about onset, triggers, and inhaler effectiveness. Your turn.
Sputum.
Sputum is mucus coughed up from lungs, indicating infection or chronic conditions. Ask about color, amount, and consistency. Your move.
What are you talking, my move? Anyway. Okay, interesting. Other general symptoms I might be, I should be asking before we go to past medical history.
Before past medical history and a respiratory history, ask about general symptoms beyond wheezing, sputum to catch systemic clues. Fatigue, fever, weight loss, night sweats, or chest tightness, as these can point to infection, example TB, malignancy, or chronic disease, example COPD. Also check for associated symptoms like nasal congestion, sore throat, or leg swelling. Heart-related dyspnea. What's next on your list?
A bit of an outside the box question, not outside the box, just irrelevant. Citrulline mallet, how much should an athlete be taking for maximum effectiveness?
For maximal effectiveness, athletes should take 6 to 8 grams of citrulline malate about 60 minutes before exercise, based on studies showing improved endurance and reduced fatigue. Higher doses up to 10 grams may help strength athletes, but timing and consistency matter more. Want to jump back to respiratory history or explore?
So 15 is good or not? 15 is too much maybe?
Grams of citrulline malate is likely too much. 6 to 8 grams pre-workout is optimal for performance with minimal side effects. What's next?
Okay, interesting. 6 to 8 grams. What about 10?
Grams of citrulline malate is safe and can boost strength endurance slightly more for some athletes, but 6 to 8 grams is usually enough for most. Want to dive back into respiratory history now?
Yes, let's go back. Let's do it. Let's go back to history, medical history taking for respiratory.
For respiratory past medical history, ask lung conditions, asthma, COPD, pneumonia, TB, or lung cancer history, allergies, hay fever, eczema, or allergen triggers, surgeries, lung or chest procedures, medications, inhalers, steroids, antibiotics, smoking, ever smoked, packs year, quit when, occupational exposures, dust, asbestos, chemicals, family history, lung disease, asthma or cancer, vaccinations, flu, pneumonia shots. These pinpoint risks and guide diagnosis. Want to move to GI history or try a respiratory case?
We'll slowly go to the case in 10-15 minutes. What about what drugs should I be asking?
For respiratory history, ask about drugs to uncover treatments, compliance, or side effects. Inhalers, using bronchodilators, example, salbutamol, inhaled corticosteroids, example, budesonide. Frequency, recent changes, oral meds, steroids, prednisone, antibiotics, theophylline, allergies, any drug reactions, example, to penicillin. Over-the-counter, cough syrups, antihistamines, compliance, taking meds as prescribed. Also ask about recent medication changes or vaccinations. Flu, pneumococcal. What's next?
Family history, social history, what shall I be asking that might be specific to respiratory?
For respiratory history, family history, any relatives with asthma, COPD, lung cancer, cystic fibrosis, or TB, early deaths from lung issues, genetic or environmental clues matter. Social history, smoking, packs year, secondhand exposure, vaping, occupational exposures, coal, asbestos, silica, living conditions, mold, urban pollution, travel history, TB risk areas, pets.
Okay, that's enough. Thank you. Before we go to GI, let's play a game. The game is going to be, you're going to present us with a case, of a respiratory case, and we're going to try and guess what that person is suffering from. It sounds so bad and evil when I say it like this, guys. The only reason I want to play this game is to be able to help people in the future. Anyway, so before we play this game, I'm going to the toilet for a minute, guys. So Grog, could you entertain our audience of 5 people and tell them a story? Maybe like a mystical, abstract story. And it's a shame I'm gonna miss this. Just for 1 minute.
In a realm where clouds danced as spirits, a wanderer named Vale sought the breath of eternity, a fabled mist said to heal all. Through whispering valleys and starlit caves, Vale chased elusive vapors, each inhalation revealing fleeting truths of existence, until they became the breeze itself, forever unbound yet unseen.
Grog, I'll be honest, I'm very interested to hear the story. So what did you say?
Miss the mysticism? I told a quick tale. Vale, a wanderer in a cloud spirit realm, chased the breath of eternity, a healing mist. Through starlit caves and whispering valleys, Vale breathed in fleeting truths, finally merging with the breeze, free but invisible. Want another story, or ready for that respiratory case game?
Yeah, let's do it. So, let's play. Give us a case.
All right, game on. A 55-year-old man presents with a 3-month history of worsening shortness of breath and dry cough. He feels breathless climbing stairs. Severity 6 out of 10. Worse with exertion, no relief at rest. No chest pain or hemoptysis, but he's fatigued and lost 5 kilograms unintentionally. He's a smoker, 20-pack years, quit 5 years ago, worked in construction, dust exposure, and has a family history of lung cancer. No fever or night sweats. What's your guess for his condition, and what questions would you ask next?
Wait, so he says family history of lung cancer, right?
Yeah, exactly. The 55-year-old man mentions a family history of lung cancer, alongside his 3-month shortness of breath, dry cough, fatigue, 5 kg weight loss, 20-pack year smoking history, and construction dust exposure. What's your guess for his condition, or what extra
So,
questions would
so
you
he has dust exposure, which don't give anything away, but maybe some kind of asthma or some kind of, I don't know, um, infection maybe. Okay, and does he have shortness of breath?
Yep. He has shortness of breath for 3 months, worsening, rated 6 out of 10, especially when climbing stairs, triggered by exertion, not relieved by rest. No asthma like wheezing mentioned, and no fever to suggest infection. But his dust exposure, smoking history, weight loss, and family lung cancer history are key. What's your next guess, or what questions would you ask to narrow it down?
Is he taking any drugs?
Good question. He reports no current medications, inhalers, or over-the-counter drugs, and no recent changes. He's not on steroids, antibiotics, or asthma meds. Your guess for his condition now, or another question to dig deeper?
The recreational drugs, smoking, alcohol?
Smart move, checking social history. He confirms 20-pack years of smoking, quit 5 years ago, no recreational drugs, and moderate alcohol use. 2 to 3 beers week. His shortness of breath, dry cough,
Wait,
5
so
kg.
he used to smoke for how long?
He smoked for 20-pack years, which could mean 1-pack day for 20 years or 2-packs day for 10 years, and quit 5 years ago. What's your next question or guess for his condition?
And you said 2-3 beers a week.
Yeah, he drinks 2 to 3 beers a week, so light alcohol use not likely a major factor. With his 20-pack year smoking history, 3-month shortness of breath, dry cough, 5 kg weight loss, fatigue, and construction dust exposure, what's your diagnosis guess or next question?
I want to do a bit of a systems review. So his main problem is the respiratory. Does he have any chest pain? Does he have any other cardiovascular symptoms?
Great. Systems review is a solid move. He denies chest pain, palpitations, or cardiovascular symptoms like swelling in ankles or orthopnea. His main issues remain 3-month shortness of breath, 6 out of 10, worse with exertion, dry cough, 5 kg weight loss, and fatigue, with 20-pack year smoking and dust exposure history. Any other systems to check or a diagnosis guess yet?
Sounds like cancer, dude.
Lung cancer is a strong guess given his 3-month progressive shortness of breath, dry cough, 5 kg unintentional weight loss, fatigue, 20-pack year smoking history, construction dust exposure, and family history of lung cancer. Next steps: ask about night sweats, hemoptysis, or occupational exposures, example, asbestos, to refine the differential. Could also be COPD, fibrosis. What's your next question or test to confirm?
I see. This is really good that you're not giving me answers to the plate. Okay, I was thinking about this asbestos. So, well, we want to do a lung cancer test, which I don't know what test it is. Is it the biopsy?
You're on the right track with lung cancer as a suspicion. To confirm, a lung biopsy via bronchoscopy or CT guided needle is key to diagnose cancer by examining tissue. But first, you'd order a chest CT scan to spot any masses or nodules, given his smoking, dust exposure, weight loss, and symptoms. Want to ask about asbestos exposure, other symptoms, example, night sweats, or plan the diagnostic workup?
Yeah, tell me about night sweats, but I don't know why what night sweats would be important, and I don't know regarding asbestos. I don't know what questions to ask.
Night sweats are important because they're a B symptom of systemic conditions like lung cancer, lymphoma, or TB, indicating malignancy or infection, especially with his weight loss and smoking history. For asbestos, ask, were you exposed to asbestos in construction? Example, insulation, old buildings, and how long often, since it's linked to lung cancer and mesothelioma. Next, you could ask about hemoptysis or push for a chest CT to check for masses, given his 3-month dyspnea, dry cough, and risk factors. What's your move now?
Hemoptysis. Okay, we did a CT scan too.
All right, good call on hemoptysis and the CT scan. You ask about hemoptysis. He denies coughing up blood, just the persistent dry cough. The chest CT scan shows a 3-centimeter mass in the right lung's upper lobe, with enlarged mediastinal lymph nodes, no clear asbestos-related pleural plaques. With his 3-month shortness of breath, 5 kg weight loss, fatigue, 20-pack year smoking, and family lung cancer history, what's your diagnosis guess now, and what's the next step? Example, biopsy, further tests?
This 3 centimeter thing sounds like cancer, no?
Yeah, that 3-centimeter lung mass with enlarged lymph nodes on CT, plus his 3-month shortness of breath, dry cough, 5 kg weight loss, fatigue, and 20-pack year smoking history, screams lung cancer, likely non-small cell, given smoking. Next step, push for a bronchoscopy or CT-guided biopsy to confirm cancer type and stage, and maybe a PET scan for metastasis. Any other questions or tests you want to add?
I don't know, what do you recommend?
For this 55-year-old with a 3-centimeter lung mass, enlarged lymph nodes, shortness of breath, weight loss, and smoking history, I recommend 1. Bronchoscopy or CT-guided biopsy to confirm lung cancer type. Example, NSCLC versus SCLC. 2. PET scan to check for metastasis. 3. Ask about recent infections or TB exposure to rule out mimics, given construction work. What do you think? Want to finalize the diagnosis plan or ask more history?
No, let's finalize it. Okay, let's do some. This is very fun. I really enjoy this. Let's do some GI stuff then. And then let's do more of this game. And we'll do one for GI and we'll do one for cardiovascular too. Anything specific I want to be asking about GI? Any red flags I should be looking out for?
For a GI history, focus on key symptoms and red flags to guide diagnosis. Key symptoms: abdominal pain, use Socrates. Site, onset, character, radiation, associated symptoms, timing, exacerbating relieving factors, severity. Nausea, vomiting, frequency, content, food, bile, blood, triggers. Bowel habits, diarrhea, constipation, frequency, consistency, urgency. Blood in stool, bright red, lower GI or black melena, upper GI. Dysphagia, difficulty swallowing solids, liquids, or both. Weight loss, intentional or unintentional. Amount, time frame. Appetite changes, loss or increase related to pain or fullness. Red flags, urgent issues. Unintentional weight loss, more than 5% in 3 to 6 months, suggests malignancy, IBD. Blood in stool, melena, GI bleed, cancer. Persistent vomiting, extruction, pancreatitis. Severe, constant abdominal pain, perforation, ischemia. Jaundice, liver, pancreatic issues. New onset dysphagia in older adults, esophageal cancer. Ask about past GI history, ulcers, IBD, medications, NSAIDs, steroids,
Okay, now,
alcohol.
dude, that's a big answer. Didn't we say to keep them shorter? What mouth symptoms may the person have? Maybe some kind of ulcers, or sore tongue, bad breath.
Mild GI symptoms include epigastric pain or burning, possible ulcers, gastritis, sore tongue, vitamin deficiency, oral thrush, bad breath, halitosis from poor oral hygiene or gastric reflux, bloating, mild diarrhea, or occasional nausea. These suggest less urgent issues like GERD, mild gastritis, or dietary intolerance, but always probe for red flags like weight loss or blood in stool. Want to dive into specific mild conditions or move to a GI case?
Let's talk a bit about appetite and weight and what I should be expecting, and things like heartburn and dyspepsia, reflux, before we go forward.
For appetite, weight, heartburn, dyspepsia, and reflux in a GI history. Appetite. Ask about changes, loss, anorexia, example, cancer, depression, or increase, rare, example, hyperthyroidism. Triggers associated with nausea or pain. Weight. Unintentional weight loss, more than 5% in 3 to 6 months, is a red flag. Malignancy, IBD. Quantify amount, time frame. Weight gain. Fluid retention, lifestyle. Heartburn. Burning chest, epigastric pain. Worse after eating or lying down, suggests GERD. Ask about frequency, triggers, spicy food, alcohol, relief, antacids.
Can you explain us how reflux occurs?
Reflux, GERD, occurs when the lower esophageal sphincter, LES, weakens or relaxes, allowing stomach acid or contents to flow back into the esophagus, causing heartburn or irritation. Triggers include fatty foods, alcohol, lying down post-meal, or obesity, which increases abdominal pressure on the LES. Want more on reflux triggers or related symptoms like dyspepsia?
Yeah, that's good. That makes sense. And then I have to kind of see what region of the abdomen is hurting, right?
Yep. Pinpointing the abdominal pain region is key in a GI history to narrow the diagnosis. Ask,
Wait.
where's the pain?
Okay. Before you tell us, let me try and remember all the regions. We have in the middle, we have epigastric, umbilical, and hypogastric. We have iliac, and then we have flank and hypochondriac, right?
You're close. Here's the correct breakdown of abdominal regions. Middle, epigastric, upper central, above umbilicus, umbilical, mid-central, around navel. Hypogastric, suprapubic, lower central, below umbilicus. Left and right hypochondriac, upper, below ribs. Left and right lumbar flank, mid, side of abdomen. Left and right iliac, inguinal, lower, pelvic area. Hypochondria isn't a region. It refers to the upper quadrants, left-right hypochondriac. For pain, ask which region hurts to guide diagnosis. Example, epigastric for ulcers, right iliac for appendicitis.
Why is the right iliac appendicitis?
Ileitis and appendicitis are distinct conditions, but they can be confused due to similar symptoms, like right lower quadrant pain. Ileitis is
No,
inflammation.
I said why appendicitis for right iliac pain.
My bad. Right iliac fossa pain, lower right abdomen, often suggests appendicitis because the appendix, located there, becomes inflamed, causing localized pain, worsened by movement or pressure due to infection or obstruction. Other causes like ileitis or ovarian issues can mimic it, but appendicitis is a top concern. Want to explore appendicitis symptoms or related history questions?
Well, I didn't understand the answer, to be honest.
No worries. Let's clarify. Appendicitis causes pain in the right iliac fossa, lower right abdomen, because the appendix, a small tube off the colon, sits there and gets inflamed, often from blockage or infection, triggering sharp, localized pain that worsens with movement or touch.
To be
One
fair,
more.
no, yes, the appendix is in the. Sorry, guys, I'm stupid. What about? Of course, the appendix is there. Okay. What questions should I be asking about dysphagia and nausea and vomiting then?
No stress, we all have those moments. For dyspepsia, nausea, and vomiting in a GI history, ask dyspepsia, upper abdominal discomfort. Where's the pain? Epigastric, burning, bloating, or fullness? Timing, post-meal, fasting, triggers, fatty foods, alcohol, relieved by antacids, associated with weight loss or dysphagia, red flags, nausea, vomiting, how often, sudden or gradual onset, content, food, bile, blood, timing, morning, post-meal, triggers, smell, motion, associated with pain, fever, or diarrhea. Also, check for red flags like persistent vomiting or blood, hematemesis. Want to tie this to a GI case or cover more symptoms?
We'll get on with more cases. Okay, what about flatulence and wind?
For flatulence and wind in a GI history, ask about frequency, how often daily, severity, disruptive, painful, and associated symptoms, bloating, cramping, diarrhea. Also, check triggers, foods like beans, lactose, high fiber, changes in bowel habits, or red flags like weight loss or blood in stool, pointing to issues like IBS, food intolerance, or rarely, malignancy. What's next?
Well, what can I ask about bowel habit then? And colors and all of this, constipation, diarrhea.
For bowel habits, constipation, diarrhea, and stool color in a GI history. Bowel habits. How often do you go? Daily, weekly, normal pattern changed? Consistency, hard, loose, urgency, or straining. Constipation. Hard stools, infrequent, less 3 week, straining, or incomplete emptying. Triggers, low fiber, meds like opioids, associated pain. Diarrhea. Loose, watery stools, frequency, more than 3 day, acute or chronic. Triggers, food, stress, blood, mucus, stool color, normal brown, black, melena, upper GI bleed, bright red, lower GI bleed, pale clay, liver issues, greasy, malabsorption. Also, ask about red flags, weight loss, fever, persistent changes. Want to move to a GI case now or cover
I
more?
want to ask, so when it comes to poop, if it's solid or if it's like, what you said, like liquidy or whatever, what does that mean? I don't know. What's the difference? Like,
The consistency of poop, solid versus liquidy, reflects gut function and health. Solid stools, formed, easy to pass, suggest normal digestion, adequate fiber, and water absorption, seen in healthy bowels or mild constipation if hard. Liquidy, loose, watery stools, indicate diarrhea, often from infection, viral, bacterial, food intolerance, lactose, gluten, or inflammation, IBD, as the gut absorbs less water or secretes more fluid. Ask about frequency, urgency, blood mucus, and triggers, food stress, to pinpoint causes and watch for red flags like weight loss or persistent change. Want to explore diarrhea causes or jump to a case?
Tell me again this answer because I didn't understand it, to be honest.
Solid poop means normal digestion with good water absorption, typical in healthy bowels or slight constipation if very hard. Liquidy, watery poop, diarrhea, suggests the gut isn't absorbing water well or is irritated, caused by infections, food intolerances, or inflammation like IBD. Want more on specific causes or examples?
No, I want. Yes, give me, because I don't understand. If they tell me the poop is not solid or it is, I don't know what that means. Does that mean what disease do they have?
The poop's consistency, solid or not solid, alone doesn't pinpoint a specific disease, but gives clues about gut health. Solid poop, formed, sausage-like, usually means the gut is working well, absorbing water properly. If too hard, it might suggest constipation, e.g., from low fiber, dehydration, or meds like opioids. Not solid, watery poop, diarrhea, means the gut is inflamed or not absorbing water, possibly from infections, viral like norovirus, bacterial like E. coli, food intolerances, lactose, gluten, or chronic conditions, IBD, IBS. Ask about duration, frequency, blood, mucus, or triggers,
I
food.
see. Very interesting. Yes, it has to do with water intake, and then what does that? Interesting. Okay. Let's talk about Audrey and hernia.
I think you meant odonophagia and hernia.
No, Audrey and hernia, being yellow.
It sounds like you might be referring to jaundice, yellowing, often linked to
Audrey
liver.
is not what it's called? Audrey, or I'm a stupid? I think, no, I'm stupid. Sorry guys, I'm looking at the case and I got confused.
No worries, easy mix-up. I think you meant dysphagia, maybe from a case
When
note.
we look yellow, what is this? Grog.
Looking yellow means jaundice, where skin, eyes turn yellow due to high bilirubin, a liver waste product from liver disease, e.g., hepatitis, cirrhosis, bile duct obstruction, gallstones, cancer, or hemolysis, red blood cell breakdown. Ask about abdominal pain, dark urine, pale stools, or fever to narrow causes. Want to tie this to a GI case or explore hernia next?
Yes. Yes, please. Can we talk about hernia?
hernia is when an organ or tissue protrudes through a weak spot in the abdominal wall, often causing a bulge. For a GI history, ask, where's the bulge? Inguinal, umbilical, epigastric. Painful, sharp, aching, reducible. Can you push it back? Associated with straining, lifting, or constipation? Red flags, severe pain, vomiting, or non-reducible bulge, strangulation risk. Want to include this in a GI case or
Let's
dive
do
deep?
let's do a CVD case. And also, before we do, so hernia is like a mass.
Yeah, a hernia is like a mass or bulge where an organ, often intestine, pushes through a weak abdominal wall spot, like in the groin, inguinal, or belly button, umbilical. Now, for a CBD, I assume you meant CVD, cardiovascular disease case, not CBD. Here's a case.
So
A
a
62
hernia is caused when we have this mass, but how is this mass caused? I don't understand. Is it when we lift something? What happens? Do our intestines break or something?
A hernia isn't caused by a mass. The mass bulge is the hernia, formed when an organ, usually intestine, pushes through a weakened abdominal wall muscle or tissue. This weakness can come from lifting heavy objects, chronic straining, constipation, coughing,
So
obesity.
what is it? Is it hypertrophy?
A hernia isn't hypertrophy, muscle growth. It's when an organ, like the intestine, pushes through a weakened spot in the abdominal wall, muscle, or connective tissue, forming a visible bulge.
And why would we have a weak spot?
A weak spot in the abdominal wall can develop from congenital factors, natural gaps like the inguinal canal present at birth, chronic strain, heavy lifting, constipation, coughing, aging, muscle tissue weakening, obesity, increased pressure, or previous
Alright,
surgery.
let's do a CVD case. Shoot it at us.
I think you meant a cardiovascular disease, CVD case, but you said CDADS, which might be a slip, maybe referring to Cidacel, or a typo for CVD case, since we
Get on
discussed
with it, dude. CVD, cardiovascular disease. No intros, go for it.
A 58-year-old man presents with chest pain for 2 hours, 8 out of 10, crushing, central, radiating to left arm, with nausea, sweating. He has hypertension, smokes, 15-pack years, and a father with heart attack at 60. What's your diagnosis guess, and what questions do you ask next?
So, 58-year-old man with chest pain. He has hypertension. You said he has swelling too.
Okay, 58-year-old man with 2-hour crushing chest pain, 8 out of 10, radiating to left arm, nausea, sweating, hypertension, 15-pack years smoking, and now you mention swelling, assuming you mean peripheral edema, e.g., ankle swelling. My guess? Acute myocardial infarction.
What are you talking about your guess? Why are you giving me your guess? You're supposed to give me a case. I'm supposed to guess what it is. This is the game, and you shouldn't tell us the answer. You should keep it a secret. We should do some Socratic questioning type thing, like we did last time. The respiratory was really good. Let's do another one.
My bad. Got carried away. Let's reset with a new CVD case, keeping it secret and Socratic. Case. A 45-year-old woman presents with intermittent chest pain for 3 weeks. 5 out of 10. Tight, central, no radiation. Worse with exertion, relieved by rest. She feels breathless climbing stairs and has occasional palpitations. What's your first guess for her condition? Or what question do you ask to narrow
So
it
it's a
down?
5 out of 10 chest pain. And how long has it been?
The chest pain, tight and central, 5 out of 10, has been intermittent for 3 weeks, worse with exertion, relieved by rest. Want to ask about associated symptoms, past history, or make a guess? What's next?
So it's been on off for the last 3 weeks.
Yep. Her tight, central chest pain, 5 out of 10, has been on and off for 3 weeks. Triggered by exertion, eased by rest, with breathlessness on stairs and occasional palpitations. What's your next question or initial guess for her condition?
Occasional palpitations mean she can feel her heart beating really strong.
Exactly. Her occasional palpitations mean she feels her heart beating strongly or irregularly, alongside 3 weeks of intermittent exertional chest pain, 5 out of 10, tight, central, and breathlessness on stairs. What's your next question to dig deeper, or got a guess for what's going on?
Okay, and well, sounds like a stable angina.
Stable angina is a solid guess given her 3-week history of exertional, tight chest pain, 5 out of 10, relieved by rest, with breathlessness and palpitations. To refine it, what question would you ask next to confirm?
I want to see if she's taking any medications. Check for, check for medication. I'm wondering if she has hypertension. I'm wondering if she has diabetes or something.
Great move. You ask about medications and history. She takes no medications regularly, just occasional ibuprofen for headaches. She denies a history of hypertension or diabetes, but mentions a family history of heart disease. Mother had a heart attack at 65. Her 3-week chest pain, tight, 5 out of 10, exertional, relieved by rest, breathlessness, and palpitations persist. What's your next question or updated guess?
Is she stressed? What's going on with her life? Social history? Is she going to work? Have a family with many people?
You dig into her social history. She reports moderate stress from managing a busy office job, married with 2 kids, no major life upheavals. She doesn't smoke, drinks wine occasionally, 2 glasses a week, and walks daily, but isn't very active. Her 3-week exertional chest pain, tight, 5 out of 10, relieved by rest, breathlessness, and palpitations continue. With no meds,
So
no
what do I
hypertension.
do to test for stable angina?
To test for stable angina in this 45-year-old woman with 3-week exertional chest pain, 5 out of 10, tight, relieved by rest, breathlessness, and palpitations. Order an ECG to check for ischemic changes, may be normal at rest. A stress test, treadmill or pharmacological, to provoke symptoms and detect ischemia, and possibly a coronary angiogram if tests suggest blockages. Ask about symptom triggers or relief, e.g., nitroglycerin response, to strengthen your case. What's your next step or question?
I don't have any other questions.
All right, you're leaning towards stable angina for this 45-year-old woman with exertional chest pain, breathlessness, and palpitations. Your plan to test with an ECG and stress test is spot on. If you're ready to wrap this case, want to confirm the diagnosis with one more question, e.g., risk factors like cholesterol, or jump to a GI case for another round. What's the vibe?
Let's go to a GI case. What was it? Did she have to get stable angina? And also, when do we have stable angina? Is it when we have a lack of oxygen and there is injury on that? What is stable angina exactly? Like, I know we had chest pain, but like in the body, why do we have it in the body?
Quick detour to clarify stable angina before the GI case. Stable angina is chest pain from reduced blood flow to the heart muscle, myocardium, due to narrowed coronary arteries, usually from atherosclerosis, plaque buildup, causing a temporary oxygen shortage during exertion, not injury or wall damage. It's stable because it's predictable, triggered by activity, e.g., exercise, stress, and relieved by rest or nitroglycerin, unlike unstable angina, which can occur at rest. Physically, the heart demands more oxygen during exertion, but narrowed arteries can't deliver enough, causing pain.
I see. Okay, GI case. Let's shoot. Sorry, guys.
Awesome. Let's dive into a GI case for the game. A 42-year-old man presents with 2 months of epigastric pain, burning, 6 out of 10, worse after meals, with occasional nausea and bloating. He denies weight loss or blood in stool. What's your initial guess for his condition, or what question do you ask to narrow it down?
So epigastric burning, you said. Epigastric pain, he feels burning, no weight loss. What other symptoms do we have?
It's a 42-year-old man, not she, with 2 months of epigastric pain, burning, 6 out of 10, worse after meals, plus occasional nausea and bloating. No weight loss, no blood in stool. What's your first guess for his condition, or what question do you ask next?
So it's worse after meals, and we have the occasional nausea and bloating, you said?
Yep. This 42-year-old man has 2 months of burning epigastric pain, 6 out of 10, worsened post-meals, with occasional nausea and bloating. No weight loss or blood in stool. What's your guess for his diagnosis, or what's your next question to dig deeper?
GERD or reflux, but this is what I'm thinking about. But let's see. Well, how long has it been going on for?
You're thinking GERD. Good instinct. The burning epigastric pain, 6 out of 10, with nausea and bloating, has been going on for 2 months, worse after meals. No weight loss or blood in stool. What's your next question to confirm GERD, or rule out other possibilities, or want to stick with your guess?
What should I be asking? What test should I do?
For this 42-year-old man with 2-month burning epigastric pain, 6 out of 10, worse post-meals, with nausea and bloating, suspecting GERD, ask, triggers, spicy foods, alcohol, lying down, relief, antacids, PPIs, dysphagia or odinophagia, red flags, past NSAID use or smoking, tests, trial PPI, e.g., omeprazole for 4-8 weeks. If no improvement or red flags, order upper endoscopy to check for esophagitis, ulcers, or Barrett's. What's your next question or test choice?
Tell me again these tests, I don't understand them.
For suspected GERD in this 42-year-old with 2-month burning epigastric pain, nausea, and bloating, first, try a proton pump inhibitor, PPI, like omeprazole, for 4-8 weeks to reduce acid and see if symptoms improve. If no relief or red flags, e.g., dysphagia, do an upper endoscopy, camera down throat, to look for esophageal inflammation, ulcers, or complications like Barrett's esophagus. Want more on how these tests work, or another question?
Alright, sounds good. Thank you for watching, guys. This was a fun episode. Peace.